Right, we are live on YouTube.
Yes.
So, should we start?
Yes.
All right, great. Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 1M Uropathology, and we are streaming live from Basavatarakam, Indo American Cancer Hospital and Research Institute, Hyderabad, via Kolkata. And we have a very interesting topic and a very, very qualified person to get onto this topic. Let me first read the topic to you, which is Hello GU, what's happening? Grossing to reporting part 2. And today we are dealing with urinary bladder, testis and penis. Handle with care. And to talk on that, we have Dr. B. Vishal Rao, who's an MD in pathology at DNB, a DRCPath from London, UK. He's a Post Doctoral fellow in Oncopathology from Tata Medical Center, Kolkata. He's an observership as Post Doctoral fellow from Hopkins Hospital, Baltimore, USA. Presently, he's a senior consultant as a pathologist in Basavatarakam, Indo American Cancer Hospital and Research Institute, Hyderabad.
ನನಗೇನಕ್ಕೆ ವಿಡಿಯೋ ನಾನು ಕಾಣ್ತೀನಿ ಅಲ್ವಾ ನಾನು ಕಾಣೋದು ಅವ್ರು
And the most important thing, he is a visiting fellow scientist in the IARC editor for the upcoming WHO classification of urinary system and male genital organs in the 5th edition. That's a huge feather in his cap, and we are really proud of him. And you can see his CV, it's a very, very interesting and very, very decorated CV with a post-MD experience of 11 years with field of interest in Genito-Urinary Oncopathology, GI and GYN Oncopathology, with many awards, awarded gold medal for paper presentation in the Young Scientist Award category. USCAP, he has been ambassador in July 2016-2017. He's a member of the Society of Genito-Urinary Pathologists, awarded fellowship as a visiting scientist in IARC, editor for WHO Blue Book. He's got more than 20 international and national publications, reviewer of 2 prestigious Indian journals, guide and co-guide for 6 theses, served as a specialist in panel discussion in various national GU conferences. Before I ask him to take over, let me request you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Rao, sir, please share your screen and let us start. Thank you so much.
Can you see my screen now, sir?
Yes, sir, I can see your screen. Fantastic.
My voice is audible?
Your voice is audible and clear. Please start.
Very good evening to everybody. Today we are meeting again for the session of grossing to reporting part 2. And last part 1 was on kidney and prostate. This time part 2 is about urinary bladder, testis and penis. So we will see first urinary bladder. So as I told you before also, before going into any grossing of any specimen, you should have relevant clinical history. That is the clinical details and radiological details. Where is the location of the tumor? How big is the tumor? Whether it is papillary, whether it is also proliferative. Prior diagnosis have been made. Prior TURBT or biopsies have been done, and ISCs have been done as and required. And if any prior treatment like BCG has been given, or mitomycin treatment is given, or any radiotherapy is given, because these informations will help us in proper reporting of the specimen, as well as grossing also. So what are the types of specimens? Usually what we get is small biopsies. We get transurethral resection of bladder tumor tissues, the TURBTs, and the partial and radical cystectomies. So first we'll see how to process the biopsy and TURBT specimens. So the biopsies are to be processed as we process routine our small biopsies. You can embed it entirely and process as a small biopsies. For the TURBTs, where the specimen is more, you have to weigh the fragments and can measure the largest fragment and try to submit entire specimen, all the fragments. So in our institute, usually we get two types of specimen. One is the TURBT biopsy, one that is superficial bits, and the deep tumor with underlying tissue for the muscle assessment. So this is how we get the specimen in our centers, and and we record our gross findings and microscopic findings as per the picture, H&E picture. So this is the final impression we give. So always write urinary bladder, TURBT biopsy, what biopsy it is, superficial or deep, and then if deep is there also. So if in this case it was invasive, so always whenever you're writing a report, you should write invasive, whether it is invasive or non-invasive, papillary, non-papillary. If it is not papillary, don't write papillary. Okay, and urothelial or any other differentiation is there, and the grade is very important. When it is invasive, definitely the surgeon wants to know whether it is invading into the lamina propria or in the muscularis propria. So you have to mention tumor invades the lamina propria, and lymphovascular invasion is not seen. Deep tumor with underlying tissue, again you have to mention that muscularis propria, detrusor muscle is identified and is free of tumor. And in case of non-invasive tumors, so you have to write non-invasive papillary urothelial carcinoma, high grade. You don't have to mention LVI and there is no invasion. So you don't have to mention lamina propria is free or not, because it is non-invasive. But there are some problem in terminologies which will deal in the later part of the talk. And again, same, muscularis propria, detrusor muscle is identified and free of tumor. So coming to the radical specimens. So before going into the radical specimens, I tell all my PGTs and myself, first you see the staging of the tumor. You should, whatever specimen you are grossing, you should know the staging of the tumor, because if you know the staging of the tumor, you will be able to give proper sections. Like in gross features plays important in all the specimen, but here it also plays important role in staging. As you can clearly see, 3B is macroscopically gross tumor. If the tumor is going outside the bladder, so it becomes 3P. And again, if you see, tumor invades the superficial inner half or outer half. So while taking this section, what you have to do is you have to take the tumor and then the muscle and the perivesical fat. So all the three layers should come in one section. If the section is very big, you can make it into two and just label it. These are the A1 and A2 are consecutive section of tumor with the perivesical fat. So processing, how you process the sample, you record the outer dimension of the bladder, dimensions of the bladder, and you record any abnormal finding on the surface if it's present, and then you can ink the entire surface usually with one color, like black is black, you can color. Try to open the bladder anteriorly through the anterior wall. Try to give a Y shaped incision, straight line, and then just opening like a Y. And then put it in a formula, 1:10 ratio. Put it in an adequate jar. If from the OT the jar is smaller one, it has been fixed and just pushed it in and sent. So please change the jar. And also, if it has sent in a formalin from OT, you change the fresh formalin. Put a lot of cotton and then try to fix. Keep it overnight for better fixation. So this is the specimen, and you can see clearly it has been opened anteriorly and you can use a probe, you can use a forceps to put while cutting to ease the cutting of the specimen. And then again you have to identify where is the tumor. But like here it is an ulcerated tumor, and accordingly you have to take the biopsies. So again, if that was ulcerated, this is an ulceroproliferative tumor, and then it's a very much proliferative tumor. And in cases of male, you will have prostate will be attached, so you have to take representative section from both lobes, right lobe and left lobe, and the urethra is there, prostatic urethra is there. Try to cut it like a shave margin and then submit it perpendicularly, which will help in assessing the margin better. And in cases of female attached ovary and attached uterus, and here in this case a vaginal tumor is there which is extending into the bladder is seen. So you have to mention those findings, and you have to record those findings. Here, as you can see, grossly the tumor has come out of the bladder and it is into ureter. So then again you have to measure it, and microscopically you have to mention it, because again it will upstage the tumor. So when you are taking what are the sections? Usually standard sections are 1 centimeter each from the tumor measurement. So you have to take representative 3 to 4 sections depending upon the size of the tumor, and try to give the tumor with the muscle and with the fat, so we can properly, it will help you indirectly help you in the staging of the tumor, which will indirectly help in the prognosis of the patient. And after giving wherever the tumor is there, you have to take the tumor sections from that wall. And then again you have to take the other walls also, like dome, anterior, posterior, right lateral, left lateral, trigone you have to take, and prostate you have to take, and seminal vesicle. Ureter margins usually our surgeon sends separately, or if it is present in the specimen, that also you can take. Urethral margin and ureter margin both. So these are the key to section, tumoral sections 3 to 4, non-necrotic area, or depending upon the size you can give according to your institutional protocol. And after that, rest of the uninvolved walls of the bladder has to be given. Prostate, both the lobes have to be given, and representative section. If many a times we are seeing incidental prostatic adenocarcinoma in old patient, so again if it is found, then we have to embed the entire prostate for proper assessment of the prostatic adenocarcinoma. Bilateral seminal vesicle has to be sampled, and if depending upon the if male is there or female is there, whatever organs are being submitted should be sampled. Again, urethral and ureter cut margin should be given. So what are the important aspects of diagnosis and reporting? So basically, you have to first we have to find out what is the histogenesis, whether it is a urothelial or it's an adenocarcinoma, or whether it is a sarcomatoid differentiation is there, any squamous differentiation is there. So these findings you have to see. Then what is the growth pattern, papillary, non-papillary, what is the grade of the tumor, what is the stage, depth of invasion, so and the status of the adjacent DCIS and CIS, carcinoma in dysplasia and carcinoma in situ, which plays a very important role in prognosis and further treatment of the patient, along with vascular invasion. So again, you will get specimen in our center. We get like this, and usually it's a radical cystoprostatectomy, and pelvic lymph nodes and ureters ends are sent separately. So this is how we record our findings, and you can record all the findings or the measurements of the specimen, and what is the tumor type, and what are the tumor site and tumor size, and what is the extension. Here it was an extensive T4 tumor, and the other lymph nodes dissection you have to do. So you have to mention, don't write just bladder, just write complete urinary bladder, radical cystoprostatectomy, whether invasive, non-invasive. I told you, invasive urothelial carcinoma, high grade it was, and it was located in the posterior walls, 3 centimeter, and it was directly invading into the prostatic stroma. LVA-PNA was seen in this case, and it was also involving the urethral cut margin. Rest of the bladder free of tumor, and lymph nodes were also positive. So whichever lymph nodes are positive, 2 out of 3 lymph nodes show metastatic tumor deposit with extranodal extension. It's very important. And size of the larger, which one? What is the size of the tumor deposit, not the lymph node. Okay, like that, in the bilateral lymph nodes were involved in this case, so it was a PT4 and 2. So proper pathological stage you have to give. So now coming to the morphology first, as you know, it translational and urothelium is there, which is 3 to 6 layers thick and have basal cells, intermediate cells, and it has a thick muscular layer and a perivesical fat. But what are the problems which we face in small biopsies and TURBTs is the muscularis mucosae, where you can see these muscle fibers and lot of blood vessels also, and if tumor is just extending here, you can say you will upstage the tumor. So we should be very cautious because of that. And usually how to identify mucosae with a propria is mucosae are arranged haphazardly, as you have seen, and they have a prominent blood vessel mark levels at their level, and muscularis propria will be thick muscle bundles. So and other anatomical histological problem is that there is well developed muscularis mucosa in less than 5% cases, and this may be organized mimicking detrusomycin, which can be mistaken for invasion, and which can and it can be a pseudo updation update of the tumor. So now we see low grade and high grade, invasive, non-invasive tumors. So low grade tumors are definitely, you can see on this left hand side, it is a low power diagnosis. So there will be mild to moderate atypia will be there, occasional mitosis will be there, and it is a low power diagnosis, and always you have to see in a scanner view or low power view, and at that level only mostly your problems will be solved, because you can see low grade just loss of polarity is there, mild to moderate atypia is there, and occasional mitosis is seen. However, in high grade morphology, you can see hypochromasia is there, and brisk mitosis is there, and prominent nucleoli is there. So nuclei may be conspicuous in low grade also, but prominent nucleoli, mitosis, increased mitosis reaching up to the surface, and mark atypia are the hallmark of high grade lesions. So if you see non-invasive papillary lesions, so these are the non-invasive papillary low grade, you can see here only in scanner view, it is low grade. Coming to the invasive papillary urothelial carcinomas, again you can see this high grade tumor, which a lot of mitosis is there, and it is just invading the muscle. These you can see they are the thick muscle bundles as compared to the just small the thin strays, muscle strays. So this was a major changes occurred in WHO 2004, which gave us a very simple algorithm. If there is moderate to severe nuclear grade is atypia is there, if it is there, then it becomes high grade, and if it is not there, and if there is loss of polarity is there, then it becomes a low grade, and if there is no loss of polarity, it becomes panlum. So panlum is basically just a hyperplasia of the urothelium, and so with a stop. So, and there will be no loss of polarity, and atypia will be very minimal. Sometimes depending on the staining, cutting, it may appear as high grade, but most of the biopsy won't show any atypia, and there will be no loss of polarity. So these are very soft points which have been cleared by WHO in 2004, which really help in day-to-day practice also. Another problem in terminology which I discussed earlier, what the clinicians say and what we say are not the same. When we say for them invasion is muscle invasion, but for us invasion means it invades lamina propria, it invades muscularis propria. So whenever whenever we say invasion, they don't they non-invasive also they will ask sometimes what is the how what is the condition of lamina propria, is it involved or not. So that is what the clinical perspective is there. So that is why when you are reporting, you clearly mention. So that is what importance of musculus propria reporting is there. So whenever musculus propria is present, you have to mention it is present and free of tumor or involved by tumor, and whenever it is not present, you have to tell musculus propria is not identifying the sign. So it solves two purposes. It helps them to stage, and it is for the completeness of the biopsy. Then they will go and do the biopsy at the deeper level. So why this superficial invasive, why they are so much bothered about? Because if you see superficial tumors which are non-invasive, they reoccur and new occurrence is also there. They undergo conservative treatment and they have a good prognosis. However, invasive tumors are more aggressive. They cause metastasis and more radical treatment is required for them and carry a poor prognosis. If you see the grade, it reflects the instability of the tumor. That is why grade is important, and stage also important for the prognosis. So why this stratification, which is very different than other tumors in this? If you see that WHO ISEP outcome, they have mentioned that different lesions have the capacity of recurrence. Like if you can say low grade and high grade have comparative recurrence rates, and grade of progression is around just more than 10% in low grade, and it is around same in Penile also. So it can progress to low grade, and low grade can 10% cases can progress to high grade. Also stage progression, they may Penile maybe some areas maybe there up to 4% which may be having invasive tumors, and it increases as you see in high grade. Also prognosis also is comparable from with low grade and high grade, almost near to 90%. So advantage of WHO 2004 was that it had the first time it gave some detailed criteria was provided at that time, and better correlation with urine cytology was done, and Penile was coined, and to avoid cancer label for tumors with excellent prognosis. But if you see the peculiarity of urinary bladder tumors, if you see the first change WHO in 1973, for which cancers after papilloma, everything which was there, they used to call cancer. But in 2004, ISEP, they after grade 1 or grade 2, mostly grade 2, they are considering as. And other organs, definitely we say cancer, whether invasive cancer when there is an invasive focus is there. So again, if you see the changes which were there in 1973 and 2004, so what they did was they changed the papilloma was same. The grade 1 tumors were labeled as Penile, and part of grade 1 tumors were and grade 2 tumors were clubbed in low grade, and then grade 2 few tumors, and grade 3 definitely were made in high grade. So earlier there were 3 grades, now there are only 2 grades. So if you see, if you use both the grades, both 1973 and 2004, then sometimes some cases which are difficult, I also feel in my practice should be grade to high grade. So these are the difficult cases where they are focally looking high grade. But again, if it is focally high grade, definitely you have to give it high grade only. You cannot low grade it. So it's I think this using both the classification may help sometime, but we have to follow what are the guidelines now. It's often low grade and high grade only. So if you see the history, how the tumors were added in 70s, late 90s, and then the new in 2005 inverted lesions were added, inverted papilloma, inverted Penile, and inverted invasion was there. So this week I got this case recently, so in which there is a downward growth of the papilla, and then there is a basiloid, this peripheral palisading is there. This is another interesting case which I already showed you. This is a primary squamous cell carcinoma of vaginal wall, and which was contagious spread to the bladder. And this case was, if you can see, P63 was focally positive and P16 was very much diffusely positive. Other markers like GATA and CK7 were negative in this case. Another case was there where the bladder tumor was there, and bladder tumor was spreading into the rectum. You can see the rectal mucosa, and these are the tumor cells, and which were positive for GATA. This was a diffuse positive for GATA, and CDX2 and CK720 were negative in this case. So morphology is morphology and workup is there, and molecular workup has also been done for quite some time, and you can clearly see that HRAS and FGF3 plays an important role for upregulation of the tumor from urothelial hyperplasia to low-grade urothelial carcinomas. And again, these the reason for recurrence and new occurrence is the gene mutation of P53 and the retinoblastoma gene, and approximately 15% cases upgrade to high grade, and where other mechanisms like ECAD and metalloprotease and VGF factors lead to invasive and then metastasis. Again, and few patients may directly have, if there is a loss of 9q, and then they may have dysplasia, and then they can get converted into high grade and then invasive. So presence of dysplasia and carcinoma in situ is very important in bladder tumors. So that is most important, and which will help in proper management of the tumor. So what are the points to remember? Bladder, again, clinical details should be there. Prior treatment should be known, like BCG or radiotherapy, or which may help us in diagnosis and proper treatment. And tumor location is important, and extent and presence and extent of the adjacent carcinoma on C2 is very important factor. And lymphovascular invasion puts the patient in very high risk, and adjuvant treatment of radiotherapy and medical therapy should be given. Sir, at this moment, are there any questions for bladder? Anybody? Hello.
Hello.
Yes, sir. Any questions for regarding bladder?
There are no questions as of now, not even in the YouTube. I think we'll progress, and at the end we will take it up as it comes.
Sure.
Is it okay? Yeah.
Okay. So now we'll take testis. So again, same before grossing and reporting of testicular tumors. Here, the clinical features, radiological features, and prior treatment diagnosis and serum markers are more important. And mostly because we don't have a facility of getting a biopsy or getting a FNAC. So the patient, usually the clinician work on the serum markers, the radiological imaging, and the size of the tumor grossly what is there. So accordingly they will do treatment. So what are the types of specimen which we receive? So we receive in our center high inguinal orchidectomies, which is a diagnostic and prognostic both procedure. Bilateral scrotal orchidectomy as a procedure for prostatic adenocarcinomas, and retroperitoneal lymph node dissection. So sometimes before chemotherapy or after chemotherapy. So according to the patient's need and patient's profile, these surgeries are done along with whatever chemotherapy, BEP, or whatever they have to give. So before going into the grossing of any specimen, you should know what is the staging. Again, you can see that many changes have few changes have been there from the AJCC 7th edition to the in the AJCC 8th edition. I think most common is this lymphovascular invasion, and so again, so according to size, as you can see from the stage, the size is very important, and tumor going into the soft tissue, epididymis, and the tunica layers and the spermatic cord. So if you know the stage, you know what are the things which are important in staging of the tumor. So you can do grossing accordingly. So these are the specimen. When the specimen comes, what you can do is just cut it into half, and what you or also you can first cut the spermatic cord margin, keep it in a cassette, and then keep it for fixation, and you can cut the testis into half, and then you can keep it in a adequate jar with formalin 1:10 ratio. So this is a specimen of testicular tumor. You can see a well circumscribed tumor is there, and with iron guanal orchidectomy, so spermatic cord is also present. So here you can see another tumor which is larger than the last one, but again definitely it is well circumscribed. You can clearly see the hilar soft tissue, the rete testis, the epididymis is also there. So and the spermatic cord. So what are the specimens sections to take? First, you have to cut the spermatic cord to avoid any floaters. So cut it and keep it in a cassette. Later you can give, and then tumor ideally 1 centimeter from each from the tumor, depending upon the tumor size, and it should include tumor with tunica layers, fat and rete testis, and epididymis should be included in the tumor. So the block must contain the interface between non-tumorous testis also, as well as the tunica albuginea, even away from the tumor. And lymphatic invasion is best appreciated in the peritumor tissue as well in the vessels within under the parallel to the tunica. So the section should include both. And when there is a multifocal tumor more than or greater than or equal to two separate nodules, additional tumor should be sampled from both the nodules. So these are the sections, important sections which has to be taken. One is the spermatic cord, as I told you, tunica tumor with 1 section per centimeter, or representing all gross in the different areas. So tumor and tunica layers, tumor with an hilum and extratesticular extension, tumor and normal testis separately, epididymis, and all the lymph nodes if they have sent, and other tissues in the specimens. So if you see after grossing, if you see before reporting, you should know what to see. So mostly they are germ cell tumors, and can be seminomatous or non-seminomatous, and depending. So that is why you should know the serum markers, the beta hCG, LDH, and AFP levels. If AFP raised, then most probably yolk sac component will be there, and LDH and beta hCG are raised, then mostly seminoma will be there. And if it beta hCG is raised very highly, then it can be a choriocarcinoma. So according to that, you have to assess how to report it. And then again, sex called stromal tumors are also there, Lidex cytolysine, those tumors are also there. So you have to see the morphology accordingly. So before going, you should know what are the tumors of the site, so accordingly, and the serum tumor markers. So you expect what to see. So seminomas, if you can see, these tumors are seen in diffuse sheets and nodules, which are separated by fibrous septars. And if you see the fibrovascular septars, and individual cells have this prominent nucleoli, and spacing is there, and clear cytoplasm is there, and in between lymphocytes are also there. So definitely this is a classic variant of seminoma. The non-classic variants of seminoma are microcystic, solid, and other variants are there. So you should be also aware of all these classic and non-classic patterns of seminomas. So because this is a photomicrograph of embryonal carcinoma, in diffuse sheets your cells have large pleomorphic areas, and they may be associated with necrosis and hemorrhage, and they have very and glandular pattern also. So if we see the more common tumors in seminomas, main tumor in testes are seminomas, yolk sac tumor, which will have shoulder double bodies, the tumor cell around the vessels, and then embryonal carcinoma, which will be very high grade tumors with necrosis and all. And then teratomas will be there in mature teratomas with area various mature and immature elements. So this is a usual ISC panel which I take. These ISCs are positive in different cases. This is the ISC panel which I usually use, and which will really help us. Like Lipican 3 will help us to find out yolk sac tumor, and CD30 is positive in embryonal carcinoma. CD117 is also positive in yolk sac tumor, and it can be also seen in seminomas. OC34 will be positive in seminomas and embryonal carcinoma, but it will be negative in yolk sac tumor. Yolk sac tumor, sulfur will be positive. So if you use these four markers, then many cases we have done a study on these markers also, which is under publication, and it has come with good results. So again, depending upon the morphology and depending upon the serum marker levels, you can see beta HCG was raised in this, and ISC helped us to find the choriocarcinoma. This is a sex called stromal tumor which we got some time back. The tumor cells are in cords and all. And this is the case of intratubular hyalinizing cytovascular nodule. And as I told you, we get lot of bilateral scrotal orchidectomies also for as a treatment of hormonal treatment for prostatic adenocarcinomas. So so we cannot. Most of them are negative, only just benign testicular parenchyma. But definitely, we have seen many cases where there is this lymphovascular emboli from prostate is there, and diffuse involvement of also prostate is also there. So you have to be very cautious while reporting. Just don't throw it in the basket saying it is benign. So you have to just see thoroughly the slides, and if any areas discrepancy are there in gross also, you have to mention. So tumor invading the tunica vaginalis are usually considered category T2. Some facts, and this is the schematic diagram which is showing all the areas and how we stage it. Okay, when it is limited to testis at T1, but if it is going to the vaginalis, it is T2. Invasion in the rete testis, as if now it is not assigned any higher category, but for all practical purpose, we recommend to record these findings. Maybe later some study may come and this may be important. So, and because as you can see that rete testis invasion has reported to be associated with high risk relapse, so maybe it may be added in the future. And so your report should always have the histological subtype. What is it? A seminoma? It is non-seminomatous. And what is the size of tumor? If it is a non-seminomatous, what is the percentage of various types? And here embryonal carcinoma plays a very important role. If embryonal carcinoma is present more than 50%, it comes into very high risk, and adjuvant treatment has to be given. So try to take proper sections and proper assessment of the tumor. And then penetration in the tunica layers. Invasion is into spermatic cord is very important because it's really upstages the tumor to T3, and angiolymphatic invasion, any germ cell neoplasia, and the margin of the spermatic cord is also important. Other microscopic findings which we have to record is usual necrosis, mitotic figure, and any other hyperplasia, latex cell, or whatever other morphology is there. And for lymph nodes, if it is involved, size of the tumor deposit we have to give, not the size of the entire lymph node. So this is how we receive a sample. Usually left testis with somatic or left high inguinal orchidectomy, and we record cord. We measure the testis and the spermatic cord, and then cut open what is the size of the tumor and what is the extension of the tumor has to be noted in the gross finding. Microscopically, again, comparing with the tumor markers, you have to tell you have to see what is the morphology. Whenever it is a mixed germ cell tumor, many a times which practically I face a problem is when there is a mixed morphology of embryonal versus yolk sac. So we have to, as I told you, the panel ISC panel, to put that ISC panel to find out what is the predominant tumor, because it will really help into the proper assessment of the patient and prognosis of the patient. So size and what is the extension, LVI and spermatic cord margin, these are the findings you have to record in the impression. So this is another case where there was few cases. This is also we are doing a study in which we have compared testicular tumors where upfront chemotherapy has been given as compared to the upfront surgery cases. So in this other case where many times when patient come, that is why treatment history is very important. Many a times a patient will come with a post chemotherapy, and you will see a diffuse a tumor bed, you will see where, and when you see microscopically there is no tumor left, mostly necrosis is there or hyalinization is there or treatment related changes are there. So in this case, patient underwent chemotherapy, and then followed by chemotherapy, treatment surgery was done, right inguinal operatectomy, along with the retroperitoneal lymph node dissection and the iliac node. So here you can see in this case there was no invasive embryonal or yolk sac tumor, but however there was a residual immature teratoma, low grade, and the tumor bed was around 12 centimeter, and other features were unremarkable. And even in the lymph node mass, there was a one conglomerated mass of 17 centimeter. We tried to give as many sections according to the guidelines, and then we didn't find much of a tumor in that. We just found immature teratoma, low grade in that. So again, in this kind of cases where there is only immature teratoma, patient is usually kept under observation and no further treatment is required. And if there is an increase in tumor markers, then the radiological assessment and then biopsies is done. So risk factors for recurrence in patients with stage 1 non-seminomatous GCT are, as I told you, lymphovascular invasion, embryonal component more than 50%, and absence of yolk sac component, and tumor stage above T2 are the risk factors. And serum markers play a very important role in testicular tumors, and elevated AFP and beta CG may indicate need of additional sections if you are not seeing typical yolk sac tumor in that. So based on this, the ICC and Germ Cell Association guidelines are there, and so depending upon the tumor markers, the stage and the stage of the tumor, these prognosis is made.
Can I ask one question?
Yes, sir.
Actually, this basically question is for everybody, because this is a very common issue which keeps coming. But I thought because you are an expert here, it was best to clarify. Many a times when patients get NACT, before the surgery, and when you get the specimen, there's no residual tumor. Everything is infected, knocked off.
Yes.
Because of NACT, and that's what. How do you handle that? I mean, how do you stage that? It would be best if you tell everybody. That would be good.
Yeah, so same as I told you, in many cases we don't find any residual tumor. So how to write a proper crossing is the key, because you have to take adequate sampling. Yes, primary we can see from the past serum markers what they have done. So AFP, beta CG and LDH plays an important role. And then when you get the specimen, try to give from different areas, gross adequately, And if there is no tumor, then you have to write no post anicity, no residual tumor is identified, and treatment related changes are seen. Microscopically, I define all the changes which are seen, like necrosis, fibrosis, and pigmented macrophages, whatever we are seeing. And then in that we say treatment related changes are seen, and whatever margins if they are clear. So they take it as a T0, and then mostly in this case observation is the key. The patient is observed, and every quarterly the serum markers are done. If the serum markers are raised, then radiological assessment is done, PET CT or MRI accordingly, and then if any other focus is there, they will confirm it either by FNAC or biopsy, and then proceed accordingly.
So you would call it T0?
Yeah, sir, because there is no tumor as such. YPT0N0.
Okay. Right, that's one very important thing, because this is very common, which keeps happening,
Yes, sir, yes.
that you may not get a residual tumor at all.
Yes.
And we had one case in the ovary where we really had to search very hard, and then finally were able to get a very small area of residual tumor, high-grade serous. And in testis, it does happen very frequently.
Yes, sir.
Another thing is this LVI, lymphovascular invasions.
Yes.
You would stress upon intraparenchymal or extraparenchymal?
Mostly extraparenchymal only, sir, because it will be better. It will be more correlating.
That's another thing which I thought everybody should know, whether you're trying, because of the vascularity part, whether it will be intraparenchymal or extraparenchymal.
Yes. Right. If we find, we have to mention it, but definitely because it will have an implication if it is extraparenchymal.
Right, great. Yeah, that's nice. Thank you. And regarding teratoma,
yes, sir.
Can you just say a few words to the audience regarding the immature teratoma and the malignant counterpart? Just a few words on that.
Actually, sir, in many of our cases, I think 5% cases which I have seen, not very frequently, there will be either teratoma which is differentiated. Now it is called differentiated, the mature one, or the immature one, low grade. Occasional we will see the neuroepithelium and all. And mostly we have tumor board discussion regarding this. If it is a immature teratoma, low grade, patient is no adjuvant treatment is given. Patient is again kept under. It is as good as zero, no tumor. So
because we look at ovarian teratoma and testicular teratoma separately. I mean,
yes,
they have a different.
So, clinically, what we discussed in the tumor boards and all is like, whenever there is a low-grade teratoma, they say only observation. Observation is only the key in immature teratoma.
Okay, right.
Because it has better prognosis and all, it is not that much harmful.
So we need to really, grasp the teratoma part very extensively. That?
Yes, sir. Yes, sir.
Yeah, because
but post-anicity, definitely that what I have seen is that we get a very low grade only. I have never seen a high grade teratoma.
Many a times in yolk sac tumor, you may not even get a primary. The secondary is more bigger than the primary.
Yes.
Then very small primary in the testis, and maybe a huge tumor in the retroperitoneum.
Yes.
It's very common. Just trying to discuss these things out, because for the rest of the people, because these are very critical areas, that
very practical point. This is the practical problem, because you see testicular tumor is all clinicians do everything. Pathologists have very less role because they all use tumor markers radiologically to treat this tumor. So they are very less dependent on pathologists.
Yeah.
So our role is very less in these tumors. So we should also think like a clinician, and we should take into account all the clinical details. That is why every organ, I am saying clinical details are very important. Talk with your physician. Discussing with your physician is very important to give. At the end of the day, patient should benefit. So any fact should not be hidden from the pathologist, and we should know everything about the patient. So better to talk with your clinician.
Another thing which I wanted to know is how frequently do you sign out papilloma in the bladder?
Papilloma, very rare, sir, very rare.
Yeah.
I think this inverted papilloma is the only one I have
No,
seen.
inverted papilloma is okay, fine, very well, but
Papilloma, very rare.
a true papilloma. I mean, that entity, trying to stress on that as a step one entity in
Yes,
any papillary neoplasm of the bladder. Papilloma per se.
yes.
You know, how frequently? I mean, in your practice, how frequently do you see that?
None, sir, none. Because I think maybe blessing in disguise, we have this tertiary center, so patient comes us very late, and usually comes with a bigger tumors and papillomas. I don't remember, sir. I have reported any papillomas. No. Low grade,
Well, you
definitely.
see,
Low grade urothelial carcinoma. Low grade invasive also. Some,
yeah, that
yeah,
that is okay. I mean,
yeah,
you see, I mean, that part is fine. I mean, when we start from there, low grade,
yes,
fair enough. But
yes,
pure papilloma, the whole entity itself is so dicey. And
yes,
you don't know
yes.
exactly where to really call it papilloma and where to call it the low grade
Nothing. That
papillary
algorithm is
neoplasm.
there at WHO, which the WHO has given the algorithm. Just
Right.
if it is just purely hyperplasia and no, I'll just show you again. Purely
I saw that.
hyperplasia.
I saw that
Yeah.
algorithm of yours. Yeah.
Yes. Yes. So I follow this. This really helps actually, sir.
Right.
So just there will be no loss of polarity will be there, and you see in low power only. Don't scanner view, I will say, and you will see there will be just a hyperplastic on a stock, hyperplastic urothelial on
Yeah,
a stock.
because if you see in this algorithm, the papilloma
Yes,
doesn't come.
yes, yes,
It's not there.
yes, yes,
I mean, it's a very. I mean, the terminology itself is highly controversial, truly
yes,
subjective, and
yes,
puts us into a very difficult. There was a big lecture by Dr. Verma.
yes,
He had discussed these controversies. He also was trying to stress upon it. There's so much of
yes,
subjectivity into it that the
yes, yes. You
clinical
cannot
picture.
definitely differentiate between a papilloma and a panlum.
Yeah, true,
Yeah.
true, true, true. And when you talk about punlub, then the whole issue of a proliferative neoplastic papillary lesion comes into play. While a
Yes.
papilloma can be just a purely if you try to correlate that with a GI papilloma, you know,
Yeah.
something like a
Yes.
hyperplastic polyp in the GI. I mean, it's not
Yes.
same as an adenomatous
Totally
lesion.
different. Totally different. Yes.
Yeah, so that's now there are you see when we start talking, then the questions start coming. Now
Yes,
there are some
yes, yes.
questions on the
Lot
YouTube.
of issues. That is what I was telling. There's a lot of issues on terminologies and what we say and what the clinician perspective also I told you.
Yes,
When we say
yes,
non-invasive, they say non-muscle invasive. They don't take
yes,
lamina propria. And many a
yes,
time my clinician asks, what about lamina propria? I say that when I have told you it is non-invasive, means lamina propria is also free. So I
yeah,
don't need to add a lamina propria, word on lamina propria. So
yeah.
these,
I know.
yeah,
It is very important. I
yes,
mean, when a tumor is not invading the lamina propria, the very concept of trying to comment upon the muscle doesn't come into picture. But then,
yes,
as a matter of protocol, one would like to complete the story so that
yes.
questions are not raised. Now, there's a question by Dr. Nabanita Das on the YouTube. I would like to read it to you.
Yes.
She says, general query, in any surgical specimen tumors, if there are no lymph nodes grossly identified, then what will be the PN? Can we call it PN0 because we have not seen
No, no,
or mentioned clearly no
definitely
lymph
not.
nodes assessed?
No, no. Cannot be assessed. Usually
Yeah,
don't write N, just write T only, T stage only.
okay. I mean,
Mm.
what I would do, Dr. Nabanita, would be I would put the PT and then I would say lymph node not assessed, right?
Yes,
And not put N0 because that will give a different connotation altogether.
yes. Definitely.
Daphne Fonseca, she says pre-pubertal and post-pubertal teratoma.
Yes,
That's another area, very critical. And the
yes, yes,
presentation is different and the type of lesions are different.
yes, yes, yes.
And
That
if you would like to
itself
say
needs
something
a
on
big
that,
lecture. That itself needs a big lecture.
or it wants a okay, fine. Dr.
Yeah.
Nabinata Gas says incidence of tumors in undescended testes in your experience.
Very few actually, very few I got. And mixed germ cell tumors usually.
Okay. Yeah, Dr. Nabanita, we do get a fair number of tumors of the undescended testis, and many a times we find them to be seminomas uh, rather than any other variants. But that might differ from place to place. We are not a specialist urological center, and like Dr. Vishal practices specialized, uropathology. Right, that's it. So let's start with the last part of it. Thank you so much.
Yes.
Nice discussion. Yeah.
Yes, sir. So coming to my last part of the talk is on penile cancers. So again, what are the types of specimen which we receive in our center is the incisional, excisional biopsies, circumcision biopsies, and partial penectomy and total penectomy depending upon the extension of the disease. So how to handle these specimen? Again, if it is a circumcision specimen, definitely all the routine what we do for all the specimen, like taking measurements and identifying the margins and inking them and fixing them accordingly. The penectomy specimen, again you have to take measurements, describe the specimen, identify and describe the tumors, and again we have to see the foreskin and whether it is medium, long, or any phimotic, and cut the proximal margin of resection and face, making sure to include the entire circumference of the urethra. So whenever we get, mostly we get partial penectomies in frozen section also. That is a challenge to report, because not because of the morphology, but to get the urethra, the skin, soft tissue margin, because urethra tend to get retract, and so we have to be very cautious while doing the frozen section. So this is a schematic diagram of partial penectomy. After submitting the proximal margin, the specimen is cut into half longitudinally, and the section is there. I have a gross picture also like this. When we get the section, so this is the tumor, also proliferative tumor. This is the skin margin. This is the soft tissue, and urethral margin will be there. So when you cut open the specimen, this is the tumor. So again, you have to take the entire section of the tumor, and then these are the margins you have to take. Definitely, this is the tumor section where the tumor, a partial penectomy specimen, in which this is the skin and the soft tissue margin, and that's the tumor. See from the front, yeah, this is that proliferative tumor. So entire length of the tumor you have to cut, and these are the margins. You can see. So tumor with maximum depth you have to see, because again staging will be there. So tumor in the lamina propria, cavernosum, spongiosum. So you have to cut longitudinally, so you can get you can assess the proper stage of the tumor. So tumor with maximum depth you should take, and then skin, soft tissue, and urethral margins are to be taken. So what are the things to should be there in the report? One is the tumor. What is the primary tumor site, size, and depth of the tumor, and what is the grade of the tumor, level, what is the extension of the tumor, the vascular and perineural invasion is there or not. In penectomy specimen, the margin of resection to be reported are urethral, periurethral, corporal, and the skin of the shaft. And circumcision specimen margin includes coronal sulcus, mucosal margin, and cutaneous margin. Common associated lesion to be reported are the penile intraepithelial neoplasm, which can be differentiated or undifferentiated, but depend upon HPV and non-HPV related. We'll see in the coming slides. So what are the key two sections for a penile partial penectomy is? We have to give tumor sections, again 1 centimeter according to the size of the tumor we can give, and entire depth possible. So it is very important you give the tumor with the entire depth possible. And skin, soft tissue, and urethral cut margins should be included, and lymph node sampling as it is sent. So histological types now, after 2014, it has been mandatory to distinguish between, because the prognosis is directly depending whether it is HPV related or non-HPV related. So non-HPV related are like squamous cell carcinoma, usual time, pseudohypoplastic, pseudoglandular carcinoma, cuniculate. We got recently 2 days back, I have kept the slide, I'll show you. And the adenosquamous and sarcomatoid carcinoma. And if you say HPV related, they are mostly basaloid, papillary, aortic, warty basaloid tumors, and the pituitary disease, adnexal carcinomas, and carcinoma that cannot be typed, or other types. So again, stage is very important. You should know always. It should be very handy. So because depending upon the stage, and this LVI also plays an important role. Earlier LVI had a very big role, but now LVI has been removed. Not that much role is there. And then in lymph node also important. Now you see the number of lymph node involved and extranodal extension. So if there is extranodal extension, it automatically upstages to PN3. So it is very important to look for extranodal extension, because it will upstage the tumor. So what are the types of infiltration? And basically they may be infiltrating or pushing type. So the infiltrating pattern is associated with high risk or nodal involvement. So we have to look into it. Penile intraepithelial neoplasms have gained many most popular now, because they can be HPV related and non-HPV related. So usually this is the differentiated type, which is HPV unrelated, and there is no coellocytosis, and P60 stain result is usually negative. Basaloid one, which is usually HPV related, and overexpressed P16, which is a surrogate marker for HPV. Well differentiated squamous cell carcinoma. This is the carcinoma cuniculatum, which I was telling you. This shows well differentiated nest, and which forming cysts like sinuses and tracts with intense stromal reactions. This is a water type. So this is how we record our findings. This is how we get the specimen, the partial penectomy specimen with usually we in our institute frozen sections are sent for all the lymph nodes. So to avoid unnecessary inguinal lymph node dissections, so we usually receive 5. These are all the specimens we receive in frozen section. So if 1 or 2 cases comes from morning till evening, we are there. So these are there, and accordingly we report it. So this is the final impression. So you have to tell whether what kind of tumor, what is the grade, and then size, depth is there, and what is the level of invasion, whether it is cavernosum, spongiosum, and or it is involving urethra. And then the LVI PNI is important, and then the margins, skin, soft tissue, and urethral cut margins are and the lymph node. So here you can see it is only cavernosum T2 N0. So these tumors can be prognostically stratified into 3 groups: that low risk, high risk, and intermediate. Low risk groups are very form like varicose, papillary, and condylarthropathy or condylomatous tumors. However, high risk include basaloid, sarcomatoid, endosquamous, or poorly differentiated types. And intermediate, there is an intermediate category of metastatic risk that include mostly of usual type. Some are mixed, and some are high-grade variants of warty or condylomatous carcinomas. So what are the clinical significant factors? As I told you, involvement of the spongiosum of cavernosum, percentage of tumor that is poorly differentiated, varicose carcinoma, and depth of invasion is important, size of the lymph node metastasis, extranodal extracapsular extension, I told you, because it will upstage the tumor to N3, and HPV status, which will help us better to stratify patients. And strongest predictive results are from combination of histological grade is there, and deep anatomical level of infiltration, presence of PNI. These factors are used for constructing prognostic index. And number of lymph node extension, also presence of more than 2 lymph nodes in one. If they send in frozen section, if there is more than 2 lymph nodes, then it increase the likelihood of contralateral inguinal lymphadenectomy involvement. So they have to do contralateral dissection also. The number and percentage of positive node involved also has an impact on survival. And all the nodes should be included in microscopic examination. Positive and total number nodes should be reported with presence of extracapsular extension. And distinction between superficial and deep nodes have been eliminated in 7th edition TNM classification. So for all the specimens which we have discussed in part 1 and part 2, kidney, bladder, prostate, testis and penis, clinical details are very much important. Prior treatment history and surgery are important. Radiological findings are correlation because size it plays important role in many tumors, almost all the tumors. So you should be aware of the size and what are the location. You can take help of the radiological findings. Prior diagnosis, if it has been done like in bladder, patient continuously come for DTU, RBT and BCG. So treatment history should be there and diagnosis should be there. So if to avoid unnecessary ISC, if it workup has already been done, you can just correlate. Okay, this is the same morphology and we can do it. Localization and size of the tumor for better grossing should be included, and capsular involvement should be mentioned in most of the tumors, and margins, which is the most important in all the surgical specimen. So inking should be done. So a long way to go, this is my hospital, and I would thank Dr. Divya and Dr. Nadeem sir for giving me this opportunity. I thank my HOD Dr. Sushila, Professor Sundaram. I especially thank my colleagues. Dr. Dagni is there, Dr. Mohan for helping me to take these pictures, and other PGs, Dr. Reshma and Dr. Meena for the pictures. Thank you once again.
Thank you so much. Wonderfully presented, excellent lecture. Can you just stop sharing so that we can see you on the screen?
Yeah, yes.
Wonderfully done, I would say. And let's see if there are any questions. Anybody in the Google Meet would like to ask Dr. Vishal. Since he's an expert in uropathology, it's a good time to ask anything. You can grill him and clarify your doubts. People are not asked. Let me see if there's anything on the YouTube. It takes a bit of time for the YouTube for the transmission delay. Can you just wait for a minute? I would like to ask Dr. Would you like to mention, coexistence of, various other issues on the penile cancers, like say balanitis erotica in the adjoining lesion, along with this tumor?
Yes. We have to mention it.
Yeah. And is it mandatory now to mention the thickness of the lesion and the depth of invasion in all squamous cell carcinomas?
Yeah, it is part of the CAP protocol also.
CAP protocol, yeah. It does change the prognosis, does it? Oral cancers, it has become.
Yeah, it has, but again, it has not totally gone, but again, it has to be mentioned because at the end of the day, the extension of the tumor is more correlating.
Yeah, there was a talk by Dr. Santosh Menon on whether the corpora cavernosa involvement has any role to play in the final outcome of penile tumors. And, tomorrow we'll have Dr. Santosh Menon talking about GynePath. So it's a separate entity.
No, definitely we will update you, sir, because the new WHO is coming at the end of the year. So maybe I'll be in a better position to answer this at that time because whatever changes are being discussed will be made.
Because the report which you showed us, 4.5 centimeter tumor, it's quite a big tumor. I mean,
yes.
The tumor
that is what I'm saying.
Centimeters.
At a tertiary center, we get very big, huge tumor. We get conglomerated masses, and we get surgeries which intestine is there and uterus is there. So everything is mixed up. So we get lot of specimen like conglomerated specimens are there. Huge tumors.
Right. So I don't see anybody asking any more questions. And so there are none in the Google Meet as well. So nice of you, Dr. Vishal, now to take out time from such a busy schedule. You also have the WHO fascicle on your head to sort that out.
Yes.
And still you take out time to give us such a wonderful presentation. Thank you so much. It's a real honor to host you here and to listen to you and to learn so much from you. And so nice of you. Thank you so much. And I would love if you could just share the PDF of this presentation so that we can share with all the students.
Sure.
It will be benefiting them. We'll be putting up your recording on the YouTube channel, as well as we'll share it with you and with everybody else. And thank you so much. Good night. God bless you. Take care, everybody. Bye.
Thank you.
Thank you. Bye.
Okay.